When the holidays start to feel a bit repetitive, reach for a Sprite Winter Spiced Cranberry and put your twist on tradition. A bold cranberry and winter spice flavor fusion, Sprite Winter Spiced Cranberry is a refreshing way to shake things up this sipping season. And only for a limited time. Sprite. Obey your thirst.
Every Who down in Who Newville liked the holidays a ton. But where to get great prices on gifts, they had no idea. None. They searched and they searched for great gifts under $25. Gifts for spouses and friends and even their toddlers. When suddenly one Who shouted, Walmart has what you want, knowing they have Lego, Tree Hut, and low prices to flaunt. So they enjoy the holiday season as Who's often do. Cheering and shouting, Walmart has incredible gifts. Who knew? Find gifts they'll love under $25 at Walmart.
Welcome to the Dr. Raj podcast with Dr. Raj Dasgupta, a show all about educating patients, students, and aspiring doctors about better patient care. Dr. Raj is a quadruple board-certified physician and associate professor at the University of Southern California. He was a co-host of the TNT series Chasing the Cure with Ann Curry, as well as a regular on the TV show The Doctors. And now, here's our show.
Hi, and welcome to the Dr. Raj podcast. And once again, what is this a podcast of? It's a podcast of wellness and goodness and just informing people about things that they will encounter during their lifetime, whether it's themselves, a loved one, a friend. It's about interesting stories and wonderful people. But today, I wanted to focus on things that unfortunately are very, very common. As you know, in the past, I talked about things like arthritis and who has that, and chronic pain, who has that. But there is a disease known as COPD, chronic obstructive pulmonary disease. And I got to tell you, like 16 plus million people have it in the United States. 65 million people around the world have this. And I wanted to actually invite someone who motivates me, who's wonderful and smart and cool and my friend, because it's my podcast. And today we have an interventional pulmonologist that's going to give us a little different take on managing people who have COPD. And I think that's going to be a good balance of medicine and what she does. So her name is Dr. Diana Yu, and I'm going to read her bio, and it's a very impressive bio. In fact, I didn't realize how smart she was. So she's an interventional pulmonologist and clinical assistant professor of medicine at the Keck School of Medicine of the University of Southern California. She is also the director of interventional pulmonary research. She completed her interventional pulmonary fellowship training at Johns Hopkins University of Medicine, Pulmonary and Critical Care Fellowship at UCLA. No comments. Go Trojans instead. and her internal medicine residency at UCI. Anteaters. She served as faculty at Stanford University of Medicine. I didn't know that. That's really cool. Prior to coming here to USC. Her areas of clinical expertise include minimally invasive diagnostic and therapeutic bronchoscopic and pleural procedures, complex pleural diseases, and lung transplant airway complications. She has subspecialty training in rigid bronch, tumor ablation therapies, and she put argon plasma coagulation. If you don't know what that is, neither do I. Laser therapy, electrocautery, and cryotherapy. Tracheal bronchial stent placement, airway balloon dilation, percutaneous trach, endobronchial valve insertion, radiolinear EBUS. You got to explain half this stuff to us. Electronic navigational bronchoscopy, indwelling pleural catheters, thoracotomy tubes, mesothoracoscopy, and whole lung lavage. Her research interests include investigational cellular and animal models to elucidate the mechanism of post-transplant bronchial stenosis and idiopathic tracheal stenosis, as well as endobronchial ultrasound, bronchoscopy-guided cardiac plexus neurolysis for the treatment of refractory tachyarrhythmias. If you are just kind of blown away and think this person is from Mars with all her intelligence and stuff, I feel the same way. With that being said, Dr. Diana Yu, thank you for being here. How are you doing?
Thank you, Raj, for having me. Thank you so much.
Let's be honest. half the people you socialize with don't know what half these things are, correct? I mean, these sounds like procedures that you do from a Star Trek movie.
I wish it was that interesting.
So, hey, let's start off with the basics. This is kind of like the meet and greet things. And, I truly just think that you are so cool on the outside. And I want, my med students to get to know your path of how you came to be this awesome, I think just very dominant interventional pulmonologist. So you didn't put in your CV. Where did you go to college? And what was your major there?
I went to UC Berkeley. I majored in molecular cell biology and minored in music there. So it was good times.
So where did the music come from? Because I tell you, my wife is huge in music. She loves piano. So where did the music minor came in and what was your instrument?
That's a whole story by itself. But so essentially, I actually played a little bit of piano and, at UC Berkeley back then, we had a Young Inspiration Gospel Choir. So it was an upper division music class. I kind of fell into it. It was kind of one of those stories where I was passing by one day, music department. I heard these crazy, awesome music coming out of, through the window. And I stopped by and I'm like, I want to try out for this, and kind of started my involvement there in music. And yeah, I stayed an additional semester for that. And it was one of the most rewarding experiences there.
So did it have anything to do with maybe a little stereotypical, because I'm Asian too, like just being an Asian daughter? Did your parents make you play the piano growing up and had to play Jingle Bells to your relatives or anything like that?
They did make us do a little recital, but no, not really. Even going into medicine, it's not something that my parents pushed, actually. They told me, you're not going to be sleeping much. So, think of something else to do, so it was basically me being stubborn that kind of led to the whole field of medicine. So my parents weren't the stereotypical Asian parents. You have to be doctor, lawyer, or engineer. So it kind of worked out for me.
So how about this? When you now looking back about your major, I mean, you went for cell bio and, it totally fits your what's called what you're doing now. But you think you may have chosen a different, what in med school and what we need to have in our doctors now? Do you think you may have chosen a different major in college? Do you think humanities? Do you think something else may have made you better well-rounded?
I think the major I chose was suited for what I studied. In medicine. So I'm glad I actually, I really do think science and medicine, they marry well together. So I really feel like I got a really good education. I don't know that I can get into Berkeley today. I think it's competitive. But yeah, I think what helped me become well-rounded is actually having everyone else around me. All my friends actually were non-science majors. So I had a group of really well-rounded friends in college. And, that kind of got me out of the stereotypical lab and, cutthroat, science ed majors. So I got a little taste of what it's like to be outside of that. So I think that helped me through college.
So let's fast forward a little bit. And now you're in med school, so you got to be honest, let's start off with what was like the least favorite subject. You were kind of like, are you kidding me? Or rotation. And what was the best where you're just kind of like, wow, this person is totally going to, turn out to be this because she does so well in this. So the worst and the best.
You didn't prompt me for this, so
I got to keep you on your toes, man. This is A game. Bring the A game to the podcast, dude.
Well, I hadn't thought about that, but anatomy was one of the classes that I really enjoyed. One of our anatomy professors from med school was actually one of my Facebook friends, and Dr. Williams. So no, I really loved it. I loved human anatomy, and this is to me, I didn't really have any specific topic or class that I didn't enjoy in medical school because I took sort of an atypical route to get there. I did some bench research at UCSF before going into med school. So I was there for about 4 years doing clinical research and So I sort of deviated from going straight from college to medical school. So I was older than my classmates, want to say about 5 years. So
Okay.
I think having that kind of approach, you're going in because you really want to study and, become a physician. So I think that kind of gave me a different motivation. So in the beginning, it was tough sitting back in the classroom 8 to 4, being in class all day. And I haven't done that in many years. So it was challenging the first couple of months when I first started. I'm like, I don't know if I can do this again. But in terms of all the topics, I thought I was just absorbing them like sponge. So, that's kind of what I recall my medical school experience. Yeah.
Well, what did you hate, dude? So you said anatomy was cool. Was there one that you could probably not want to do again or have less rotation or subject?
Well, I thought immunology was very, very interesting, but it is so complicated. You just feel like you think you know something and then you realize I don't know anything. So,
correct. And get my back on this, Diana. Like when we don't know something and when we see those complicated cases, it's the immune system.
It's the blame it on the rheumatology.
Yeah. It's an interleukin of some number.
Exactly. It's something that you feel like you get a grasp on, and then you realize it's so complicated, and you can spend your whole life studying this. So, some of those things are frustrating.
So with your answer of liking anatomy, you know what I mean? Many people who love anatomy and formaldehyde go into surgery. How did you choose to go into internal medicine, which is the coolest residency, but how did you choose that and not delivering babies and taking care of kids and peds? Why us?
So I actually it was not a straightforward path to pulmonary critical care medicine for me. I even taking a step back, I thought I wanted to become a pediatrician. I actually volunteered in the Children's Hospital ER at CHLA, actually, throughout my high school. The entire 4 years, call me a nerd, but for 4 years, I was in high school. I volunteered in the ER there, and I loved working there. So I thought, okay, for sure, I'm going into pediatrics. Even in college, I worked at Children's Hospital of Oakland, and I did the same thing. I volunteered the entire time I was there, and it was like solidifying I really want to do this. I want to be a pediatrician. And then I did one rotation of pediatrics as a medical student. I said, I don't want to do this. It's what I discovered was that I loved kids and working with them, but sometimes it's hard to you can't instruct a crying child to hold their breath and, so I can listen, so there are a lot of components that you don't realize if you're just an observer versus the person actually taking care of them. I realized I like healthy babies and I don't like to deal with critically ill babies. So it's crazy that one block I said, no, I'm doing adult medicine. So I turned to internal medicine. Then I realized there's a whole field of subspecialty within internal medicine that can get me into more of the procedural, hands-on sort of, non-surgical, but very procedural oriented field. And I initially thought that I wanted to pursue gastroenterology.
Yeah.
I don't know. Yeah, I don't know what I'm thinking. Sorry to all my GI colleagues and folks that I love. But I discovered that my true passion was taking care of critically ill patients in the medical ICU, like the quote unquote liver bombs and people who come in massive bleeders. And, in those cases, unfortunately, GIs, they can't really do anything. We have to really stabilize them first and take care of them. I realized that that's where my passion lied. And, I had a really good female mentor at UCLA when I was a pulmonary critical care fellow. And before that, she actually was also in my residency program. And Dr. Liz Turner, she actually was very instrumental in guiding me to really just pursue PCCM. And that led to my transition to pulmonary critical care. And IP is a whole different thing. It's like that came with another obsession of wanting to master like a subspecialty skill set that became like becoming an airway surgeon, if you will. And to have the capacity to take care of patients with massive airway bleed, critically narrow airways, and much more. Like I just got more into like, okay, well, I don't want to feel helpless when I have these patients that come through. Like I want to be able to take them to the operating room and take care of these patients. And that came later too. And so, every step of the way, it was like, kind of a surprise to me. I didn't think I was going to end up where I'm at today.
I got to tell you, you got a lot of energy. I don't think many people understand how much freaking training you've been through. So you took a 4-year gap, then med school. Then you did 3 years of internal medicine residency. Then you did a 3-year pulmonary critical care. And then I got to tell you, when you do that extra training at the end, obviously I went the route of sleep. I mean, you did your extra, is it 1 year? Or how long is an IEP fellowship, interventional pulmonary?
That's 1 year, but I was a masochist. I did 2 years because they offered an additional research year, which was very helpful. And so, 2 more years on top of that. I think I should have done neurosurgery.
So I got to tell you, you got this like 8 years of just that training stuff, and was it really the interventional pulmonary? Was it the desire? Because I know what you mean. It's kind of like, hey, we are okay at the airway as critical care. Yeah, I kind of like the pleural space a little bit, but did you want to be the master of it so you wouldn't depend on other people? Was that your drive to be almost a surgeon? You know what I mean? Was that kind of like what made you want to go into IP?
Yes, I think you summarized it well. I think part of it is that, I think wanting to really master a subspecialty skill set. I mean, you can't get there without training and just a lot of sacrifice. And I feel like I wanted to be able to do that. And so, 2 years over there was like one of the most challenging years, of training for me. But that really put me to be able to face anything. So I really feel, that it was worth the investment and the time and, sacrifice in every aspect, personal sacrifice, just a lot of things. But in the end, I feel very confident in what I do. And I'm very thankful, for my mentors to really push me hard. I mean, it was to the point of, wow, it's like, why am I doing this? It's self-inflicted. Why am I asking for more punishment? But, in the end, it just, it worked out, and I'm very glad for it.
So, hey, I'm going to kind of piggyback, and you said the word mentor. And, one thing I'm a big proponent of is, I really support women in the workspace, especially when it comes to medicine, home critical care, and any field. So my question to you is, for all my women med students and residents who think about this, I mean, how was your journey? Because you're so awesome. And I think you're such a great role model for other young women out there. Choosing this like critical care field, which I'm not ashamed to say, it's kind of like a boys' club. I only see a lot of men around me, which is kind of annoying. My mentors were all women. I think they're great. How was your journey going towards all the way to, interventional pulmonary with not a lot of women? And do you have any things to say about encouraging, other women med students to go the way you do?
I mean, that is a whole podcast by itself, I think.
You want to come back already? We didn't even finish this one yet.
Yeah, definitely. I'll take that invitation. I think the main thing, I'm glad you had a lot of female mentors, because I can't say that I have. I do along the way have had very solid critical care mentors, female mentors at UCLA. I have it was very female dominated. They still are. I'll give shout out to Tisha Wong and Jane Dang and just awesome people over there. That is really, you're right. Our field is we are the minority, and further, especially interventional pulmonary. I mean, when they did the poll several years back, it was 15% female in the field of pulmonary. So it's a very male dominated field. And it's not so much that we don't have the opportunity. I think that, people prioritize different things in life and, things happen, right? I don't think that there is a push to not have females or women in this particular subspecialty. I think that it does take a lot of years of training and sacrifice. And, a lot of times you kind of come across a crossroad where you have to make a decision. Do I want to do more training, or do I want to have a family? There's just a lot more for us to think about and address. It's more challenging. So I do think that it's hard to have it all. I think it's good to have that aspirational goal to say, hey, I want to have a solid career at the same time, be able to have a family and, be a mom. And there's just a lot more layer and component. And I do think I highly encourage all the female medical student and listeners to really not let that discourage you, but you do have to kind of think about realistic goals and plans, right? I do think that you have to be realistic and be okay with what you are prioritizing, because things change. And I think if you have that in mind and you have some female mentors along the way, you'll make the right decision. But I do think that we could afford to have more women in our field. It is definitely a boys' club still. And I really have no problem working with my male colleagues. I actually enjoy that. I've kind of always been in that group. So I don't know, I've kind of acclimated myself to that. But I don't know if that answered your question.
I'm telling you, I always love talking to you. I just could let you banter forever. But let me switch to gears. I did promise we're going to talk about COPD, and I think this is very important. And like I said earlier, the numbers are staggering for everyone listening today. 16 million people plus have COPD in the United States, 65 million plus in the world. And, I'm not an interventionalist like Dr. Yu. I use a lot of medications. And, when we talk about COPD or any disease, we think about things that reduce mortality, stop smoking, do you need oxygen, are there bronchodilators, inhaled steroids? But, unfortunately, that doesn't make everyone breathe easier at the end. And there are certain people who have, what we call advanced refractory COPD that need to see a Dr. Yu who does bronchoscopic interventions. So I want to kind of list a couple things, and Dr. Yu could kind of like give some definitions about what they are. So if you meet criteria to, you're advanced, you're refractory, I already did everything a medical pulmonologist can do. They were talking about something called lung volume reduction in general. I know you don't do it. Can you explain just to my listeners over here, what is lung volume reduction in general, and why does it help people?
So, to simplify, think of it as, COPD is a big umbrella term, and you have different types of disease processes that fall under this chronic obstructive pulmonary disease, right? So you have your emphysema. It's just a word for destroyed lung, if you will, instead of being like I explain this way to my patients, instead of being a tight sponge, it looks more like a big honeycomb with holes in it. So you have destroyed lung. You have chronic bronchitis, which you have very excessive mucus secretions and production. So you're coughing all the time. So there are different types of phenotypes and different types of COPD. For people with bad emphysema or destroyed lung, if you have a particular area that's worse than other parts of the lung, simplified is if you get rid of that problematic area, perhaps you can breathe a little bit better. So when they talk about total lung volume reduction surgery, they mean finding the most destroyed part of the lung that traps air, that contributes to your symptoms of shortness of breath, and getting rid of that space so that you can perhaps breathe a little bit better. So that's the quickest sort of way to summarize that. So that's surgical intervention. And, the other surgical intervention that I'm sure you'll bring up is lung transplant. And that's a whole different topic by itself. But not everyone qualifies for lung transplant. In fact, it's a very specific inclusion and exclusion criteria for that. That requires a whole different field of subspecialists to deal with this. And where I would come in is basically, if you ran out of medical therapeutic options to optimize symptomatic management, then you have the next non-surgical option of bronchoscopic lung volume reduction, which kind of means that we put like a little tiny umbrella or like a little tiny valve that's a one-way valve that allows air to come out but not go in. And that actually non-surgically makes a particular part of the lung ineffective. So that particular part of the destroyed lung that traps a lot of air, we basically close that particular, we close the door, if you will, to that particular room that's causing a lot of problem. So, I come in to non-invasively place these one-way valves. And there are other devices that, that is also a bronchoscopic catheter-directed therapy for bronchitis, which is a rheoplasty that we can talk about in a little bit. And there are also bronchoscopic procedures, that actually cause lung denervation, and that reduces risk of COPD exacerbation. So there are a lot of other medical devices that are in the works now, and they're undergoing pivotal trials now to see if we can help patients who are not surgical candidates to see if we can help them breathe better.
Well said. I mean, let me just take a step back so we could see where you're jumping in. So for my dorky med students and residents who may be listening to this, lung volume reduction surgery is surgery. When you see some of these pink puffers, blue bloaters, whatever they are, you're like, how can you tolerate this? And, one of the classic trials out there was something called the NET trials, the National Emphysema Treatment Trial, that said, hey, in certain people who have certain distribution of their emphysema in their lung, and they have certain, pulmonary function test criteria, they may get some benefit. They even use the S word, survival, in some cases, but it's surgery. And that's where Dr. Yu comes in with her bronchoscopic interventional pulmonology, techniques to kind of, lack of a better word, mimic the surgery and doing something minimally invasive. And I think we're going to kind of narrow into something she does very well, which is the valve placement that you already kind of hinted at. So my question for you is, how do you know that someone with COPD is a good candidate for what you do, which is that bronchoscopic volume reduction? Who would be a good candidate for that? How would you explain that?
So, I think that they have conducted multiple studies so far that kind of look at data. And, when you conduct these multi-center trials to look for safety and efficacy and feasibility, that's when you kind of derive your sort of numbers and criteria. They narrow down the exclusion and inclusion criteria to see,
okay,
we have tried these valves in this particular set of population with XYZ, and they've done better. So the more you study these patients, multi-center, randomized, it's hard to randomize this because where it's going in. But those numbers actually give you some idea. And I think that by doing so, you come up with, it narrows down your criteria to say, hey, we know for sure that these types of patients would benefit more than others. And, I'm very strict about adhering to these inclusion-exclusion criteria, because the point of placing these valves is to make sure that the patients feel better at the end, knowing some of the known side effects, right? I mean, we know that anytime you do manipulate the airway and put a foreign body, that you can have side effects. And understanding that, you want to make sure that patients who actually get these valves will benefit. A lot of times they come to our office thinking that this is a magic bullet that's going to cure them and make them run a marathon. And, I think that setting realistic expectations is very critical, because if you're very functional, even though you meet criteria on paper, I still would say, that they're not good candidates, right? Because chances are they're going to actually suffer the consequences of side effects more than the benefit. So some of these selection criteria are that you definitely need to have emphysema on the CAT scan.
Okay.
Your BMI has to be less than 35. So I think that that's also critical. You can't have someone who's on steroids all the time to control their COPD. So you need to be stable with prednisone dose less than 20 milligrams a day.
Okay.
Obviously, you cannot be an active smoker. You need to have quit at least 4 months. And
sure.
Obviously, you can't be an active smoker, because the first thing you should do is quit smoking to feel better. So that's another criteria. And there are specific breathing criteria, so pulmonary function tests that you need to do, and there's a certain number that need to be met. So, I don't know how much detail.
Well, let me interrupt you for a second. I think this is the interesting part. When we do lung volume reduction surgery, it was predominantly emphysema in the upper lobes. Can someone be a criteria? Can someone have this bronchoscopic intervention and the predominant emphysema is anywhere in the lung, not just in the upper lobe?
Yes. So you can have both the homogeneous and the heterogeneous pattern, which means that all of your lung is destroyed evenly, or you have a particular case where a particular lobe looks worse than others. So they both meet criteria, but a specific number in the breathing test varies. If you have a homogeneous pattern of emphysema, your RV has to be greater than 200% rather than 175%.
Wow. That stands for residual volume, everyone, on a pulmonary function test. You just went for the RV. I'm just being a translator.
Yes. So people trap a lot more air. So you need to demonstrate that you trap a lot more air if you have a homogenic pattern, which means that a lot of the lung looks evenly destroyed, right? So you need to really demonstrate that if we were to block off a particular room or the lobe, that you would actually improve. Because if you have even pattern and you block off one area, that can actually make your symptoms worse, right? So they really are shooting for that particular number, and that FEV1, 15 to 45%. And this is specific for post-bronchodilator response. So you can't have someone whose number is pre-bronchodilator. It has to be a post-bronchodilator FEV1, 15 to 45%.
Now, let me ask you a couple more questions. So what about, you said risks, you know what I mean? So for someone listening, they're like, okay, I have advanced COPD, I have to see Dr. Yu. There are some things she's going to order to make sure I'm a criteria. What is the biggest risk of doing this procedure? Besides expectations, what's the biggest risk?
Biggest risk is that up to about a third of the patients develop pneumothorax or a lung collapse. And so that is a pretty, significant number of patients. Not everyone who has lung collapse requires a chest tube or intervention, but that is a very high number. But if you think about it, we are actually closing a door to a particular room in the lung, and that in and of itself, it actually causes that lung to collapse, right? It kind of makes sense that it happens, and not everyone requires a chest tube, but we keep patients in-house for at least 3 days because most of lung collapse happens within the first 3 days. So we keep, this is not just a procedure you get done and you walk out of the hospital. You have to stay in-house for at least 3 days to make sure that this side effect doesn't happen. And if it does, then you have, medical professionals who can actually intervene and help you. So, I always have to talk to the patients, you will be stuck with us for 3 days in the hospital. And this is sort of the potential problem that can arise. And, we discuss this in detail in our clinic when we talk about potential lung volume reduction. And, I think a thorough sort of discussion that you have with the patients is important, because when I go over some of these numbers and side effects and what they would expect, gives them a bigger picture. And, I have a lot of patients who come in feeling like, I want this is a magic bullet. And then we have this long discussion about the data, some of the adverse events that can happen, and et cetera. And then that motivates them to say, look, maybe I'm not using my inhaler on a regular basis.
I'm good.
Maybe I need to go to rehab and participate in rehab a little bit more. I was looking for this magic bullet, but it doesn't seem like that's the case. So, once we have this thorough discussion, I have patients who just say, you know what, I think I'm good. Let me just work on more of the non-procedural ways to improve my symptoms. So, I have half the patients. I think I'll wait. So
that's interesting.
Very critical. Yes.
So I want someone to kind of visualize, what actually happens. So of course, like many things in procedural medicine, the actual flight time is not as long as the whole preparation and post. So are these patients, are they put on a ventilator and you go through their endotracheal tube? And what are you using to deploy? And what exactly are you deploying to collapse this lung? Can you kind of, in this layman's terms, kind of explain what exactly happens to this patient when they come in?
So another aspect that we observe when we determine whether or not you're a good candidate is to make sure that you can undergo, we call it general anesthesia. So we put you to sleep completely. So there are different types of anesthesia where you could be in quote unquote twilight, where you're somewhat aware of what's going on, but you're not. So there are different kinds of procedures and different kinds of anesthesia. So we put all the patients under general anesthesia. So we completely put you to sleep. We completely take over your breathing. So we put a breathing tube, put you on a machine that helps you breathe during the procedure. The procedure itself is not a very long procedure. I mean, we can essentially do cases in about half an hour.
Wow.
30 minutes. So we go in, we take a look, obviously you planned which lobe that you're going to intervene.
Okay.
So you already have sort of a map of, by looking at the CT scan, putting it in a software that tells you whether or not which lung has the most destroyed lung and whether or not they have, we call it fissure completeness. So you want to make sure that each room has its own closed off wall. So if you have different lobes that communicate with each other, or we have collateral ventilation, that's not a good candidate to actually undergo this treatment.
Makes sense.
We also look at all these things beforehand. So let's say I decide, okay, the right upper lobe seems to be the best area.
Sure.
We already know that before we go in. Then we deploy, these are things that you can Google. We have two different kinds of valves. Spiration valve is one of them. It looks like a little umbrella. We have a Zephyr valve that looks like a little, it looks like a little fish mouth, one-way valve.
Yeah.
So there are two different kinds of valves that we can deploy particularly for this. And, we use the catheter through the bronchoscope, which is the size of your pinky. So essentially a camera that goes in through the airway tube, and then we isolate to this area and we deploy. We essentially shoot off these valves into these areas to close it up. So, once you deploy them, like we talked about, it won't allow air to go in there. Things come out, but it's a one-way valve.
Yep.
So, and then we wake you up from anesthesia, pull the breathing tube out, and it's a relatively quick and safe procedure that can happen, even if it's a complicated case, less than an hour. So
nice.
The procedure itself is a short procedure, and like we discussed, because of the pneumothorax rate, we keep the patients in hospital for a couple of days to monitor with x-rays.
So let me ask you the follow-up that everyone wants to hear. So in general, let's say there's no complications. When do patients, start feeling better? How do they describe the feeling better? And can you kind of parlay that with one of your personal success stories? Of course, be HIPAA compliant, but tell me a story.
Main thing is this. So study outcomes, they've looked at 6-month and 12-month outcomes. So this isn't something that you're going to come out of the hospital feeling like a new person.
Honest. You're so honest, dude.
It takes some time for you to actually notice.
Okay.
So that's why we do sort of a couple months follow-up. And what we also did, all the studies in the past that they've looked at the pulmonary function test, the breathing test that you did before the procedure, they do it after to see if there's any benefit. And the benefit, how they measure it, is that your FEV1 has improved more than or equal to 15%. And just about half the people who underwent this treatment actually had a significant improvement, greater or equal to 15% improvement. So it's not just subjective improvement of, I feel better, I can do more chores in a day, I can walk further distance without being winded, but you actually have objective numbers that improve, right?
No, that's great. Yeah.
So it takes a few months for you to actually, once you get over sort of the side effects, and, another side effect that can happen is COPD exacerbation.
Sure.
That can happen, but over a longer period of time, because you are symptoms of shortness of breath actually improves dramatically, subjectively and objectively. So if you are a success story, it works out very well. And, I have one of the patients who all that patient wanted to do is be able to play with his grandchildren. It's very realistic expectation. He wasn't trying to run a marathon. He's like, I get so short of breath when I pick up my grandkids, and I just want to be able to play with them. And after doing a case, you can see, as you have sort of blunting in the diaphragm. So when you actually have COPD, your lung just gets bigger and bigger. And at some point that your diaphragm gets pushed down, and that really also contributes to your sense of shortness of breath. And there are people who, their cases, the successful cases, you can actually see that you regain some of this cosophrenic angle. So you have sort of the normal architecture again after the valve gets placed and the lung collapses. So there is physical evidence, and some of these people do well. So that patient ended up coming back and doing very well. It's like, objective benefit reflected in the pulmonary function test.
Yeah.
And also like, hey, I get less tired. I'm able to actually be more active. So these are very rewarding cases if it really works out. So patient selection is important. So you need to really make sure that your patient will benefit. Otherwise, don't offer it, because, if think of it as your family, like you're going to offer it to people is going to potentially benefit, not potentially get worse. There's nothing more, not satisfying than to see patients get worse and frequently come back to the hospital and end up in the ICU because of, inappropriate sort of patient selection. That's really heartbreaking to see that. So
now let me just kind of not really switch gears, but, kind of expand upon, Dr. Yu said appropriately, COPD is a mixture of many different diseases. And we're talking about the classics. When we talk about the endobronchial valve placement, we're talking about emphysema. There's also something called chronic bronchitis. I think a lot of us in med school kind of remember, what was it like? I coughed for 3 consecutive months for 3 consecutive years or something like that. But anyways, there's another, procedure out there, and I don't believe it's FDA approved yet. You know what I mean? And we mentioned it when me and you were talking. So it's called bronchial rheoplasty. It's really targeted towards the chronic bronchitis patient, which is a different, like you used another medical term, phenotype, another different type of COPD. Can you just kind of explain a little bit about what this is? Because I know you had to explain it to me, and it's not really electricity, or maybe it is. So can you explain it?
So this actually is it's a therapeutic rheoplasty. It's an endobronchial catheter-directed therapy for chronic bronchitis. What it means is that, instead of throwing valves, we use the same bronchoscope, go in and use their catheter, which it's a catheter that's designed where it's like almost like a mesh balloon that expands out and contacts the airway. And what it does is that it actually delivers non-thermal electrical sort of field into your airways. And what it does is, the problem with chronic bronchitis is that these patients actually have significant production of mucus because they have a lot of goblet cells, and their respiratory epithelium is just filled with a lot of cells that produce a lot of gunk. And the purpose is to actually deliver this non-thermal electrical energy to your airways to basically kill off some of these old epithelium that causes a lot of production in mucus, and then replace it and regenerate it so that your epithelium resembles more of a normal epithelium of a person who doesn't have chronic bronchitis. And by doing so, you have reduction in mucus production, and symptoms get better. So you're not constantly hacking this thick mucus that you can't cough up that's causing you to have shortness of breath. So, we enrolled two patients to this clinical trial, which is, we don't have to, this just started. So we are one of the few sites in the country that actually recruited and enrolled and treated 2 patients already. So
wow.
How it goes, but it's
how many procedures is it? Is it one procedure? Is it all lobes? Is it one lobe? I mean, now you got me curious. I wasn't going to ask you that. So what is it?
It's 2 procedures. We do each lung in each session 1 month apart.
Okay.
So we do one lung first. We start with the right. We treat individual lobes like upper and all the subsegmental airways. We treat all the lobes in one session, and then a month later we treat the other lung, the opposite.
Now is this general anesthesia? Are you knocking me out and paralyzing me, or not as much as so when you did the bronchial valve placement?
It is under general anesthesia.
Wow. Well, okay. So I want to make sure I get to one of my last questions with you. But once again, for those listening today, the reason why I brought Dr. Yu here is because I refer these patients to her. And I think it's so amazing that, once again, the theme of this, podcast is advanced refractory COPD. And it's amazing how there are these things that you may be a candidate for now or in the future. But Dr. Yu wanted to talk about something that's very near and dear to her, which is a horrible consequence of people who smoke, which is lung cancer. And, I can't even pronounce or think of all the things she does to help people with her procedures, diagnosis, therapies. So I'm going to let her kind of dictate this part of the answer. Like, can you just tell me, when you have someone who unfortunately presents to you with lung cancer, what is your role? Is it more of diagnosis? Is it more of therapy? And what are some of the impressive things that you do?
So mainly for lung cancer patients, when they first present, and obviously any cancer, we need to diagnose first. So we need tissue diagnosis. We talk about tissue is the issue. So we always have to get tissue to diagnose what kind of cancer. So, we deal with, as interventionalists, we deal with not just lung cancers, we deal with other metastatic cancers from let's say, colon cancer that spreads to the lung, and we have kidney cancer spread to the lung, breast cancer, and et cetera. So we deal with, unfortunately, a lot of cancer patients initially when they present with, well, I just had a cough, I got a CT scan, now I have this spots in the lung. How do we know this is lung cancer or not? This is where we come in to diagnose lung cancers by biopsying these nodules. And there are different types of modalities that we use to diagnose lung nodules. So we have, bronchoscopic, you can just go bronchoscopically diagnose them using different types of ultrasounds for imaging. And we also use navigational bronchoscopy to, we use electromagnetic field sort of to regenerate some of these airways to target. And so it's not playing video games. We kind of get a specific spot that we want to get to. So we navigate through using a bronchoscope and sticking a needle and biopsying those. And so
it kind of sounds like a video game, Diana.
In the future, I think that's sort of what we're thinking in the future, right? So then to further advance that, we have robotic bronchoscopy that is of the future in terms of not just diagnosis, but also therapeutic. So, what they're trying to do is, hey, could we create some of these catheter devices that actually deliver energy to cook or freeze these cancers to treat it? So that's sort of the future where you come in, you have a particular spot, just one spot. They're not a good surgical candidate. We stick a needle, diagnose it. We stage the cancer. If we confirm this is a lung cancer, is it the stage 1, 2, 3, and 4? If it's an early stage cancer and the patient's not a surgical candidate to take it out surgically, could we actually just treat it while we're in the airway? So that's sort of the ultimate future of interventional pulmonary. So we go from anywhere from diagnosis of lung cancer to, when you talk about therapeutic approach, we're talking, let's say, unfortunately, you have a cancer that's advanced, cancers that's grown into the airway and it's bleeding and you're coughing up blood. Or sometimes cancer spread to the lining of the lung that causes fluid to build. We call it pleural fusion. So you can have a lot of these unfortunate symptoms from advanced lung cancer or metastatic cancer. So we also treat patients like that. So if you're having massive bleeding from the airway, coughing up blood, you can take it to the operating room for a rigid bronchoscopy to go in. We use all different types of techniques like that argon plasma coagulation unit, the type of ablative therapy, and also laser and different things to freeze, burn, and core out some of these tumors so that you're not bleeding anymore. So we also place stents if your airway is squished because a tumor is squishing your airway and you can't breathe. We can open up that airway, put a stent in so the tumor doesn't invade back in. Obviously we work alongside radiation and medical oncologists to treat the patient from every aspect and every angle. And also we place these catheters inside the chest wall, the pleural lining, where if you have a fusion of fluid that's reaccumulating frequently, instead of sticking a needle in and draining it all the time, we place more of a permanent catheter so that you can have more autonomy at home. You can drain it yourself. You don't have to come see us anymore more frequently as you do. So there are different therapeutic options that we also offer to patients. So we manage things globally from diagnostics to therapeutics in managing not just cancer patients, but a lot of non-malignant or non-cancer patients as well. So it's a very, very rewarding field, and I'm very glad I'm in it.
Well, hey, I'm going to squeeze in one more question. And, honestly, you don't need me to boost up your ego, but I've seen patients I send to you where there's these big tumors in the airway. And after you do what you do with your toys, these big masses are gone and they can breathe and it open. And it's just amazing what you do. And can you just tell me, who do you think would be the right person to go into this field for my students and residents? Is it people who like to poke people with needles? Who should go in this field, Dr. Yu?
I think you can comment on that more than me too. I think obviously the drive. I think you and I and all of our colleagues do what we do because we are truly passionate about taking care of people, and critically ill people. If I always think of it this way, I've had families go through cancer and I mean, obviously people go into medicine, I believe, still for noble reasons, right? To really help people. But, I think the main thing is a couple of things that would self-select people who would get into pulmonary critical care and eventually interventional pulmonary would be, obviously you can't be someone who, I don't want to say afraid of blood, but you need to have someone who could actually be level-headed in a very critical, chaotic situation, right? I mean, you have, if everyone's running around panicked, you have to be the grounded one who can basically stay focused and take care of these things. So if you have that tendency where things don't really distract you and you're able to have sort of laser focus and you're able to take care of these patients in chaotic situations, I think that's critical. You need to have sort of the, I don't think people are naturally just born with everything. You go through training and you hone in your skill sets and you become better at what you do, but you need to have sort of that tendency. Like if you say, hey, I'd rather look up textbooks and studies and come up with, a research project, or I want to come up with different medical therapeutic modalities. If you're kind of that book nerd, then maybe critical care and interventional is not for you, right? Because we're very hands-on, active, very action-oriented people. So I think that's critical. Obviously the patients to be able to go through all the trainings and know that at the end of it that, you become a better person for it. So what else? I think.
No, dude, that was a great answer. I was going to say, for someone who tried to convince me off camera, like, Raj, this is not my thing, I'm a little shy. Yeah, you took up pretty much a whole hour, dude. So let me just do my closing right now. I just wanted to say thank you for Dr. Yu coming today. And she is my friend and my colleague. And I asked her to be here because I think she's just a great role model, not just because she's a woman, because she just is. And obviously, like the fellows that we both work with speak very, very highly of her. So that's why I wanted her to be here. And hey, I'm not joking. Are you going to come back on my show if I need you? Is that cool?
Anytime for you, Raj. And thank you so much for, I think your platform's great. This is very informal, very casual. You're a very driven and passionate person who's like, you can't hide that. You can't hide that smile and enthusiasm. It's like, it is infectious because I can come in saying, oh man, I need another cup of coffee. And then, here you are bubbling with energy. So I really think that, what you do is very important. And thank you so much for having me here.
Aw. All right, everyone. That is the Dr. Raj podcast for this week. Talk to you later.
Thanks for listening. This has been a production of Ars Longa Media. Our producers are Madison Linden and Chris Brightigan. Our executive producer is Dr. Patrick Beeman. This podcast is for educational purposes only and not intended for medical advice. Ars Longa, Vita Brevis.
Hey, Ryan Reynolds here, wishing you a very happy half-off holiday, because right now Mint Mobile is offering you the gift of 50% off unlimited. To be clear, that's half price, not half the service. And Mint is still premium unlimited wireless for a great price. So that means a half day, yeah? Give it a try at mintmobile.com/switch.
Upfront payment of $45 for 3-month plan, equivalent to $15 per month required. New customer offer for first 3 months only. Speed slow after 35 gigabytes if network's busy. Taxes and fees extra. See mintmobile.com.